Yes, you are audible.
Yes, sir. Yes, sir.
Okay. Uh, and I guess this is primarily for students in surgical oncology. That's the idea I got. And the topic given to me is surgical strategies. So my intention would be to talk only about the surgical strategies, and I'll leave out uh, diagnostic aspects and the workup and all. So that would be too long. So you see, I mean, we all know that these are some of after possibly a grade 4 GBM. Uh, this is a disease which has possibly one of the highest local recurrences, and that's a very challenging for a surgeon, and it can easily vanquish the vanity and valor of any surgeon. And the reasons are pretty obvious. They go to a very large size before they become evident. They are diagnosed. That's just part of the problem. The other is that they have a very all different kinds of biological behaviors, and they occur in an area which is full of very different kinds of organs and major vessels. So when we think about surgery for such tumors, we naturally think about various kinds of surgical supports, like support from the vascular surgery, from urologists. Even if we don't have a surgical simulation available, which I believe most of us do not have, it is better to sit for long hours for a long time at the CT scan console and get through all possible permutations, combinations of how to deal with the disease in draw. So a lot of the surgery is actually carried out prior to entering the theater, and that could really help, because if you are continuously getting surprised by a new finding, then you are in a different situation. You may need to prepare for nerve monitoring, especially for tumors arising in the lumbar region, L2 to L5, and pre-sacral, of course. Obviously, we need a very expert anesthetic management because of fluid and fluid losses, fluid management, blood losses, and many of these patients may actually be malnourished and would need a good rehab. And they give you enough time to for a week or 2 weeks to prepare them. Post-operative monitoring in the initial couple of days at least should be intense because of multivisceral resections which can occur sometimes. To simplify the approach to these tumors, compartmental concept has been proposed. This concept of compartment in sarcomas came from Nikhil, in whose description the entire retroperitoneum is an extra compartmental area. So there are no basically tumor limiting barriers in the retroperitoneum. Nonetheless, this is how the modern concept goes. So in the center, you have the major vascular compartment. Then on both sides, the perirenal space, the anterior perirenal space, posterior perirenal space, and this is the peritoneal cavity. And these are the important structures which are in each space. So the posterior perirenal space is the simplest to handle, and the most difficult would be the central greater vessel space. The spine would also be in this area. As you go to the anterior pararenal space, on the right side, you have the duodenum and the pancreas. We must remember that almost all of D3 and fair amount of D2 is entirely retroperitoneal. And especially if you have a leiomyosarcoma in this region, I personally would be very circumspect about this being involving the duodenal wall itself, And these are the patients in whom I would probably do an upper GI endoscopy and duodenoscopy. Obviously, when we're dealing with such wide areas, we need a lot of versatility in your surgical procedures. There is no fixed uh, kind of steps for retroperitoneal sarcoma excision. So you have to borrow from various experiences from dealing with other advanced malignancies. So distal body and tail pancreatic lesions where you do an anterior posterior rams. That could come in handy in knowledge of dealing with the structures in the left upper quadrant. And possibly with the development of peritonectomy procedures for peritoneal carcinomatosis, I believe we get a lot of exposure to the retroperitoneum more commonly, entire retroperitoneum from the diaphragm up to the pelvic diaphragm. And that also helps. One must be conversant with resection of the liver and Golgi junction. And obviously some basic urological and vascular surgery knowledge and experience comes in handy. So this is an area which is generally considered inoperable. The reason is very clear. We have the aorta. This is after a resection of the pancreatic malignancy. The current concept of divestment of major vascular structures, especially the common hepatic and the celiac and the superior mesenteric, could also come in handy when dealing with some difficult situations in this area. That's the anterior pararenal space for tumors here. So in divestment, you dissect out the adventitia and you can still preserve the vessel. This could sometimes come in handy. So like the idea is to borrow from different experiences from different kinds of surgeries and apply it to one particular tumor. Resectability needs to be determined, obviously. These are the standard criteria for unresectability, widespread peritoneal metastasis, because that makes the resection non-curative. We just saw how the celiac superior mesenteric invasion would jeopardize a curative resection in R0 and R1. And an unplanned R2 resection also has uncertain palliation. The small bowel mesenteric root is another difficult area. Porta hepatis for right upper quadrant tumors is an absolute no-no. If it is involved, it's very difficult to resect these tumors with a clear margins. Bilateral renal involvement, obviously. Spinal involvement is generally considered contraindication, but there could select some patients for curative resection. Aorto-iliocaval resections, they are very exciting area, but actually look at entire series for any surgeon or any institution, you'll find that not more than 10% would require a major arterial resection. Aorto-iliac resection. Caval resections are more common for two reasons, because about 10%, 5 to 10% actually arise from the inferior vena cava. And then there could be secondary involvement of the inferior vena cava. Then, of course, if you're dealing with a recurrent tumor, you may have a different set of resectability criteria, looking at the poor prognosis and possibly possibility of metastatic disease, which could be concomitant or could come up very soon. Obviously, we treat patients, not tumors, and comorbid patients, nutritional status, and those things need to be taken into account. So you see how the right upper quadrant tumors could be challenging. It's not always the inferior vena cava, but it's the porta hepatis. So if you have a tumor which grows between the IVC and the porta, it's very difficult to remove these tumors completely. And this is an area of common area of inoperability or unresectability. We also need to understand that how aggressive they should be, because many of the surgeries would need a resection of the colon, kidney, or other organs. And local recurrences can occur in up to 30 to 50% of cases. So at that point, again, you may need to deal with the same structures once again. And you may not have too much of a bandwidth of how much you can resect at that time. Additionally, there are certain tumors which not only recur locally or have a lower local recurrence rate in the retroperitoneum, but can have a higher metastatic rate. So if you have a very low-grade tumor, which is less likely to metastasize, would be more aggressive in the primary setting with an oncovascular or multivascular resection. Similarly, even if you have a metastatic disease or a recurrent tumor in the retroperitoneum, where R0 resection is unlikely, but it's a functioning tumor, we'll probably go ahead and resect the tumor. On the other hand, a tumor, say, leiomyosarcoma, a grade 3 dedifferentiated liposarcoma, which has a very high rate of metastasis, one would be try and balance how much of critical organ, if they're just abutting, not clearly infiltrated, not inseparable, how much aggressive would be on that count. And for recurrent tumors, low-grade tumors, serial scans could help you decide on whether you would need to wait. And for certain primary high-grade tumors, if they have a previous CT scan, because these patients may have multiple consultations, they have spent a few weeks, you can use that to consider whether you would the growth rate merits neoadjuvant chemotherapy. So this is a kind of a suggestion for a well-differentiated liposarcoma, where the local recurrence rate is the predominant and the distant metastasis rate is practically nil. You would be quite aggressive and you can do your plan multivascular resection if needed. On the other hand, if you have a dedifferentiated liposarcoma grade 3 or a leiomyosarcoma, you would be a little conservative in removing organs which are just abutting and not clearly infiltrated, because these have a fairly high distant metastasis rate. And LMS leiomyosarcoma, this is the major mode of failure of these tumors. If a PET has been done, the FDG ability of these tumors could also be a guide that these are more aggressive tumors, and possibly for some of them you may even consider neoadjuvant chemotherapy for whatever it is worth. I'm sure this would be discussed in the panel, the role of neoadjuvant chemotherapy. So I'm skipping it here. Once decided for resection, you must plan it well. All patients would have a mechanical bowel preparation. For a non-obstructed kidney, especially if there is no renal dysfunction, one would avoid sending the ureter, because actually it may lead to a higher incidence of ureteric injuries. DTPS scan to differentiate between the differential renal function between the two sides is not always essential, because a CEC is usually done. But if there is a gross difference in the morphology, one of the sides is shrunken, smaller in size, or hydronecrotic, or the corticomedullary ratio is altered in patient, with diabetes and hypertension, it is safer to do a DTPS scan, so that you know what kind of postoperative renal dysfunction one can encounter. And if one of the kidney is already removed, especially if it is on the right side that you are dealing, because the right vein has a single drainage. So one can plan for an auto transplant or a revascularization of the left renal vein if the right has been removed. And suprarenal IVC has been removed, then the left renal vein would need to be revascularized. That's the safer way. We'll come to this issue later again. If we think that for the left upper quadrant would do possibly a sphenopancreatectomy, we must vaccinate these patients appropriately and prepare for a diaphragmatic resection in those patients. Since patients are not always aware of what befalls them, how much of the tumor removal includes removal of adjacent organs and what are the consequences, it needs a good preoperative counseling about bowel dissection, about nephrectomy, and the immediate postoperative concerns, about blood transfusions. And one thing which goes unaddressed most of the time is the possible long-term morbidity, which, especially for young patients, could be very vital. You see a lot of them could have sexual dysfunction, which later on is a very distressing situation. If you're planning a vascular involvement, obviously you need to sound up your vascular surgeon. It's better to involve an expert, ensure that you have appropriate size grafts, and if you're trying to dissect the suprarenal vena cava or here to iliac dissection, you may even need a bypass facility. Our external iliac artery, if resected, needs to be reconstructed. Here to iliac would need to be reconstructed. These are all very uncommon conditions, less than 10%. Generally, one would not plan to resect the hepatic artery or mesenteric, but sometimes you may end up with an accidental injury to one of these, and then you may need to reimplant or repair them. The external iliac vein, especially if it has been chronically obstructed, can be resected and may not always need a replacement. But the suprarenal IVC would always need to be replaced. Infrarenal IVC and the iliac veins, one may omit a reconstruction if it's been a long-standing obstructive development of collaterals, if there is a very heavy contamination, or if there is massive hemorrhage and you have to get the patient out of the theater fast out of the is only that you get a higher resection rates or the resection rates. They have not been shown to improve upon the overall survival. In fact, tumors which need major vascular resections have a poorer survival because it's the biology which determines vascular invasion, and it's the biology which determines the long-term survival. But if done properly, well planned, the long-term patency rates are good, and the patients definitely benefit. If an unplanned vascular resection carries a very high mortality and morbidity, and should always be avoided. If a bowel surgery is also done, one must take care to do it in a kind of no-touch technique with use of staplers, cutting staplers, and if a prosthetic graft is used, either there should be treated with antibiotic or there's some silver-coated grafts which could possibly be used even in place of a concomitant bowel resection. The intraoperative conduct, you have to plan your incisions carefully. You should be prepared to extend the tumors in the thorax if needed, or into the inguinal region for iliac fossa and inguinal extension to get a better exposure. So these are all innovative surgeries, and one must be prepared to do that. The principle of a good sarcoma excision, as enumerated by Enneking, is that you should be cutting to normal tissues at all times. In a primary setting, it could sometimes be possible. And it is for this reason that a lot of bowel resection is done. It's not that the bowel itself is infiltrated all the time, but it's the mesocolon or the mesentery of the bowel which is infiltrated. And the mesocolon, once infiltrated, that part of the peritoneum needs to be taken out. And that's how you get good R0 R1 dissection. Centripetal dissection, yes, I mean, there could be some difference of opinion on how you go about it. Whether you approach the central vessels first or you mobilize the tumor from all around and leave the most critical part for the last. Depends upon the situation. There is no ground rules, fixed ground rules for this. One must be careful about finding unexpected metastasis in the peritoneum and decide whether one needs to go ahead or not. And segmental ureteral involvement must be appropriately managed. The crux of the matter always lies with vascular resections, which are more difficult. If you see a primary involvement with the vessels usually occurs in veins because many of the sarcomas could arise from the IVC. A secondary involvement, on the other hand, could be involving both arteries and veins. And arterial resection is usually not needed unless the adjoining vein is also involved. So most of the time, an arterial resection also entails a venous resection. The arterial section would always need to be replaced and reconstructed, and most of the time it is advisable to reconstruct the vein as well. So the arterial section is always for infiltration. They are thick wall structures, but a venous resection may be needed only also for encasement because it's quite difficult to separate the veins from the encased tumor encasement all around it. An isolated arterial involvement is there. Contralateral functioning kidney and its vascular pedicle must always be safeguarded before one knocks up the ipsilateral kidney. The renal pedicle, how to handle the renal pedicle involvement. So if the right kidney and suprarenal IVC have been removed, but the IVC drainage was blocked for a long term preoperatively, you could possibly leave the renal vein draining to the lumbar, the gonadal, and the azygous system. But if it is during the surgery that you are first knocking up the suprarenal IVC in the right renal, you have to have established revascularization of the left renal vein. And on the right, like said, if the left is not functioning adequately or already resected earlier surgery, one must try and one has to consider reimplantation of the right kidney if it is better. A renal sacrifice for ureteral involvement should be avoided at all costs. The bladder is treated on its merit. If the trigon is involved, possibly you cannot save the bladder, and you should think about an anterior extension and urinary diversion. For more superior involvement, limited involvement, you can go partial cystectomy, with or without augmentation. Colon is the most commonly involved bowel. B3 can be repaired. You may not always need a formal resection. D2 resection would also possibly entail a pancreatic resection. And these are very tricky situations. One would generally try and avoid a pancreatic duodenectomy along with a major retroperitoneal sarcoma excision because the issues of we could be also having some vascular resection, renal resection, and these are difficult situations. So by and large, these are situations we would possibly consider using some adjuvant chemotherapy, making the tumor less vascular, stabilizing the margins, and possibly also consider some preoperative, postoperative radiotherapy, intraoperative radiotherapy, try and avoid pancreatic duodenoscopy. pancreatitis concomitant. One has to be conversant with supralevator expressions when dealing with pelvic sarcomas so that we do not end up with double stomas. Spine involvement is generally considered a cause for unresectability because a spine involvement also means many times concomitant vascular invasion of the major vessels, the aortoiliac and caval vessels. And R block dissection and R dissection becomes much less likely with spinal involvement. And there are operative technicalities and an availability of expertise to be combined because spinal surgery may need a different positioning on the table and sarcoma excision may need a different positioning, so we need to do a phased excision. But it's not a complete no. Sometimes you may be able to dissect some limited spine involvement. So this patient with an intradural extension was resected. This was treated with a preoperative radiotherapy because spinal involvement, bone involvement, you never get wide enough margins. Recurrent disease, either it's recurrent only in the retroperitoneum or metastatic or a combination of both. With each episode of recurrence, we must remember, we all know that a patient can have multiple dissections for recurrent sarcomas in the retroperitoneum. People have dissected, all of us could have dissected 5, 6, 7 times. But the resectability decreases with each episode of recurrence, and the prognosis also worsens because the tumors become progressively more aggressive, and the surgical excision itself becomes more challenging because the tumor, the healing tissue, the fibrosis, and the tumor is difficult to differentiate between the two and find the right plane of excision. The tumors become more invasive; they are more infiltrated. And options for multivessel dissections dwindle because you may have already dissected a kidney or a part of the colon, a large part of the colon, or so many things. But because local recurrence still remains one of the most common causes of death in retroperitoneal sarcomas, especially low-grade tumors with low metastatic potential, we must think about the resection of these patients after possibly a watchful waiting. For certain tumors, particularly for well-differentiated liposarcomas. Delaying a second surgery may help in a more complete resection with better long-term control. And the patients who benefit most from re-resection are those with low-grade with unifocal recurrence after long disease-free interval after the first surgery, with no tumor rupture in the previous surgery because that's more likely to result in more multifocal and more number of recurrences, and an estimated growth rate of less than 1 centimeter per month. These are the favorable ones. A multifocal recurrence, intraperitoneal deposits, and especially when previous section was piecemeal or tumor rupture, they are the poorest considered for a resection. Metastatic disease has often been dissected, but one needs to be careful about ruling out other sites of metastasis other than lung and liver. The commonest dissections have been performed in the lung, but occasionally for the liver as well. Leiomyosarcomas tend to metastasize to the liver more commonly than any other tumor type, but they are also more aggressive tumors and they would metastasize into the thorax as well. So one needs to be careful about upfront metastasis the moment you see that. These are the standard criteria for pulmonary metastasis. Obviously, a disease-free interval is a good surrogate marker about long-term disease control. And even, a local tumor recurrence is not an absolute no-no, but these are difficult situations. And these need to be considered in a sarcoma board. One needs to plan out well. Then there are unique tumors, functioning paragangliomas, which occur in the aortic paracaval areas, which is fairly sensitive to many drugs. And then there are certain non-surgically curable tumors like givings, where one would consider surgery as the last. But paragangliomas are basically a surgical disease. Uh, some of them can be treated with PRRT. Uh, this is a case in point. The recurrent metastatic paraganglioma operated, I think, a couple of times earlier. This is a hydronephrotic non-functioning kidney, and there are multifocal recurrences, all of them. And these are extremely vascular. You see the vascular contrast and the contrast enhancement of the tumor. And these are extremely uh, vascular tumors, but it's worthwhile resecting them because they cause functioning paragangiomas can cause a lot of symptoms, and resection provides a good palliation to them. If we need to resect the source, we need to be careful about the lumbosacral tract, the femoral nerve, and this is where one area where you need nerve monitoring. It could help, but most of the time these are thick nerve trunks. They are not infiltrated usually, and it's possible to preserve them and preserve limb function. So to summarize, surgery remains the cornerstone of long-term control. There is no copybook technique. A large experience with different types of surgeries needed to handle these tumors adequately. So one needs to be well versed in gastrointestinal, HPB, urology, vascular surgeries. It's better to work as a team. You need an expert pathology to guide you how much to be aggressive for each tumor at different points of time in the natural history of that tumor. And the aggression of surgery has to be balanced in the biology, the organ function available, and the medical condition of the patient. For recurrent tumors, timing is crucial, and the intent. Sometimes you may do a planned auto resection for just symptom palliation. Radiation till date has not been found to be of great benefit. In fact, this trial was negative, but we can discuss that in the panel discussion, because possibly some subgroups could benefit from preoperative radiation. Neoadjuvant is has been tried and is being investigated in the STARS-2 trial. So we'll talk about that a bit. Metastatic disease again has a limited role of surgery in unselected cases. So when I was given this topic of the surgical strategy, it almost sounded like I have to talk about the battle plan. So this was actually my first slide, which I've kept last now. That you must know the enemy, know its location well, assess its virulence, think of allies. Those are your other surgical specialties, medical oncologist, radiation oncologist, your radiologist, your nuclear medicine guy. Plan the execution, the incision, how you are going to intraoperatively manage it, how much you are going to extirpate. You must have backup strategies, and you must prepare for a future recurrence, because most of these, at least half of them, are going to recur someday. So in this era of robotic surgery and great advancement in surgical technology, this is one disease where a skilled surgeon still makes a lot of difference in the academic outcomes. Thank you for your patience.
Thank you, Dr. Chandra. I think that was a very comprehensive summary of such a vast topic, and the analogy to the battle which you used was good, and I think Dr. Pradeep will agree with that. So with this, I think, do we have questions? So since we don't have any questions, we can move on to panel discussion, and I request Dr. Vivek Mangla to start the panel discussion.
Are you seeing my screen?
Yes.
No.
No, not as yet.
Just a minute. Why is it not showing my screen? Now?
No.
Not yet.
Yes.
Just a minute.
If I may ask, Dr. Somesh, sir, can you hear me?
Yes.
Sir, do you have any, in your own experience, do you have any experience with preoperative radiation? I know you said it's with some trials, but then in your experience.
Yeah,
Uh,
one of the cases I showed you, the one with spinal invasion. Yes, we did use radiation. I don't know how much it helped. That patient failed in the thorax later on.
Right.
But the spinal involvement remained under control. So I guess it might have helped.
So, sir, any red flag or anything to be taken care of when you radiated the patient?
Obviously, if you're radiating in the upper quadrants, we know the radiation tolerance of the liver and the contralateral kidney. And
Right.
The moment you are approaching the midline, you have to think about critically affecting these structures. Possibly a pelvic radiation for pelvic sarcomas could be because you have narrower margins there, and
Right.
the radiation protocols for rectum and pelvic organs have been quite well established. And we are going to resect the radiated organs. So once we are going to resect the radiated organs, it becomes much more safer than preserving radiated small bowel or a kidney or a liver.
Sir, I'm Dr. Shefali. So I'm a medical oncologist. So just from the medical oncologist perspective, I just want to ask you one question. So amongst all the GI sarcomas or retroperitoneal sarcomas, so we know that liposarcoma is one of the groups. I mean, basically the dedifferentiated or that type of liposarcoma, large retroperitoneal, which can benefit from the pre-op radiation. The trials have shown that many times, though we do not have a level 1 evidence yet. So, and we know that if it is a large retroperitoneal sarcoma, you are almost having close margins every time. So what is your take on in these kind of liposarcomas where we can have a beneficial effect of radiation? So is this the correct time so we can say with confidence that, okay, this is the subgroup where we can incorporate pre-op radiation?
Subgroup analysis of the STRAS trial indicates that possibly the well-differentiated liposarcomas, some of them can have a better control with preoperative radiation. But then jury is out, and I think we treat each case on its own merit. We cannot have a blanket policy for all large retroperitoneal sarcomas.
Right. Thank you, sir.
And sir, another quick question. Any experience with chyle leaks post-operatively in such patients?
Yes, that's a possibility, and when we're dealing with the upper quadrants, fortunately, I do not have had any experiences. But then chyle leaks, I mean, you can get a chyle leak spontaneous also. So we have treated spontaneous chyloscystitis. You have to be conservative about it.
Right.
If it is from the abdomen, if it is in the thorax, obviously you can think about clipping the thoracic duct, doing a thoracoscopy.
Somesh bhai, good evening. This is Rudra.
Hi, Rudra.
Yeah.
Are you in India or somewhere else?
No, India only. So my point was, whenever we have such large retroperitoneal sarcomas, the idea of giving pre-op radiation is that when you take out the tumor and ultimately whole of the gut goes into that space because it is pre-displaced before and it get replaced into the same fossa. And after that, radiating means you are only radiating the intestine, not to the tumor bed actually. So that
Right.
is why.
So we do not radiate post-operatively at all.
So that is why ideally pre-op radiation is the ideal, Otherwise, you don't radiate post-operative.
Correct. So very few centers have experience with IORT, and even fewer centers would have the facilities for IORT. That again is not proven, but whoever is used have shown some results. If we are doing a preoperative radiation, if we are doing considering radiation at all, it has to be preoperative in form of a tumor painting. There is also some thought about changing the fractionation, because using long duration of radiation, then waiting for some time after 4 or 5 weeks radiation, you need to wait another. So you might end up waiting for a long time and allow a tumor regrowth, which so what you have kind of gained on the swings, you lose on the merry-go-round, that kind of a thing. So you might think about short burst radiation, as in rectum hypofractionated regimes. I suppose all that will come up in future.
Thank you, sir. Thank you.
Yeah, I think Dr. Mangla, you can take over and start the panel discussion.
So I think I must say that Dr. Somesh has actually answered most, or rather almost everything that we could have discussed. And at the outset, I thank Dr. Shefali and Dr. Nikhil for giving me this opportunity. I would also like to refer all the people who are listening to this and who are going to see this video later on YouTube to refer to the last presentation of about, I think, fortnight back, which dealt with neoadjuvant and adjuvant chemotherapy as well as chemoradiation and radiation for these tumors, because that's a very that's a field where a lot of work is probably being done, but considering the rarity of the disease and relatively paucity of data, there is very little information about, as Dr. Somesh also pointed out, about what exactly to do in a given situation. So I would like to introduce my panel. Okay. So I welcome Dr. Somesh Chandra, Dr. Pradeep, Dr. Tarun, and Dr. Jitender for the panel discussion. I request all 4 of you to please unmute yourself. And at any point in time in the discussion, any 4 of you, if you want to just stop by and make a comment, you are more than welcome to do that, because somehow most of the things have already been answered. So my things has now become more like a cases being presented. So jumping over to the cases straight off, 35-year-old lady who presented with right lower limb edema and a lump in the right side of abdomen for the past 6 months. When she came to us, she actually came on a stretcher. She was absolutely unable to walk because of the painful swollen tender limb. And there was a large abdominal mass which was occupying nearly the entire right side of the abdomen. So we did a PET CT. I'm playing the CT images for everyone to see. The chest didn't show any metastasis. There were no lung mets, no bone metastasis. And as we go down to the abdomen, we see that the liver is normal. There are no metastases in the liver. And as we go down, we see that there is a hydronephrosis on the right kidney. There's a large mass in relation to the IVC with a thrombus in the infrarenal IVC extending to the right iliac veins. As well as the left iliac veins. We see down in the pelvis, there is a lot of collateralization between the internal iliac system on both the sides, the right and left side. And this is one that you would commonly see with these, especially the slow growing tumors, wherein there would collateralization would develop from one side to the other. The biopsy for this lesion was a grade 2 leiomyosarcoma. So my question to Dr. Jitender is that when would you routinely do a biopsy for all retroperitoneal tumors? And if yes, what are your reasons for doing so? And then Dr. Tarun could take up the question if selective, when he would do a biopsy and when he would avoid a biopsy.
Hi, Dr. Vivek. Thanks for the question. Routinely, we should do biopsy in all cases until unless your imaging is characteristic of a liposarcoma, well-differentiated liposarcoma, in which biopsy is not mandated. But the biopsy will give us very useful information in the form of the histology of the tumor, the grade of the tumor, which has very important treatment implication, and also we can prognosticate the patient. So we should do biopsy in all cases, except it's a characteristic liposarcoma.
Dr. Tarun, I think Dr. Jitender has answered both sides. Would you be selective or
Right.
you would biopsy all lesions?
I would prefer biopsying most of the lesions.
Okay. So where
I
would
would
you
prefer-
avoid a biopsy?
Where it's, like you said, where it's well differentiated liposarcoma, where it's very characteristic on the imaging itself.
Okay. And say, for example, you've got a tumor which is not very looking not very invasive, not looking like invading a lot of structures. You're not planning any neoadjuvant therapy. There also you would consider a biopsy, even if it's not a liposarcoma.
See, I don't fear. I mean, I'm more concerned, particularly if it should not be any lymphoma which requires a non-surgical treatment. That is my main concern to begin with.
Yeah. So that's
So, so only if it is, as in, I agree, there are characteristic features where, you know, you can kind of get a, think of it, whether it's a lymphoma or no, when there are more nodes involved, it's a central lesion, rounded nodes. But still, to be sure, I would want to biopsy the lesion.
And also, these all are extensive surgeries. Mostly will require multivisible sections. You need to counsel the patient, prognosticate the patient. At the outset, with the biopsy of histology and a grade, you can prognosticate the patient, and also it will be helpful to plan your surgical treatment also.
And Dr. Pradeep and Dr. Somesh, would you like to add something here?
So there was a question in the chat box for upfront operable lesions. How important is the biopsy? Obviously, we are talking about operable lesions because unresectable lesions you would biopsy anywhere. So that question doesn't arise. Yes, it is advisable. All major centers world over advise that you must do a biopsy. The risk, the downside is needle track contamination. Literature says that it's less than 2%, 0.3 to 2%, and if you do it in a coaxial way and an extraperitoneal approach, it is really not a great concern. So you lose little by, and with a biopsy, I mean, we know everything about the disease. The patient and the family doesn't know anything about it. So knocking off a kidney, or I mean, you have to talk about or counsel the patient all about that. And without it, you have to have the patient's comfort and participation in the treatment. And they know that this is confirmed as malignancy. I think it helps to carry on the entire.
Thank you, Dr. Somesh. So, Dr. Pradeep, in this patient, you've already seen the CT video. What would be the treatment options? How would you go about it rather than how generally people would? I would ask you, how would you go about handling this patient? And according to you, what would be the indications for giving neoadjuvant treatment? And in your practice, what would it be usually, neoadjuvant chemo or neoadjuvant radiation? Dr. Pradeep, please.
So as we can make out, it's a large tumor with sort of a thrombus in the IVC, and the resectability looks doubtful. So I would prefer to give a neoadjuvant treatment here. It's a leiomyosarcoma, so my neoadjuvant strategy would be pre-op radiotherapy before undergoing surgery.
Any of the panelists wants to add something or differ in their opinion in terms of leiomyosarcoma and neoadjuvant radiation versus chemotherapy?
Yeah, please go ahead.
Yes, sir. Leiomyosarcoma is not very radiosensitive, and the main problem with leiomyosarcoma is distant metastasis and not local recurrence. So even if you want to plan a neoadjuvant treatment, neoadjuvant chemotherapy will be better in this case rather than a neoadjuvant radiation. And one more thing, I think we can add an MR venography also in this to look for the IVC wall involvement, or it's a bland thrombus. Is it so that can also be considered in this case.
That's a very valuable input. Dr. Somesh, your choice in this patient would be a neoadjuvant. First is whether you would like to upfront operate upon this patient. We must mind that this patient has an acutely swollen limb as well, which needs to be tackled. And probably you would like to add some oral anticoagulation, some anticoagulation, and then probably stabilize this patient before getting this patient to surgery. And if you are planning a neoadjuvant approach, what would be you prefer, chemotherapy or radiotherapy?
The answer to the second part is chemotherapy. Looking at the kind of vascular involvement, we also have to consider that this could be a primary leiomyosarcoma of vascular origin. That's a possibility. Such tumors and those with vascular secondary vascular infiltration have a higher incidence of metastatic disease and with a poorer overall survival. And for those reasons, the neoadjuvant chemotherapy is the preferred option.
Dr. Vivek, can I interrupt? Sorry.
Yeah, sure.
So my point is, if we deem it unresectable because of the large thrombus and because of the criteria, so are we clear in our intent when we decide for chemotherapy? Will it be neoadjuvant? Will it be palliative? Or you will like to assess and decide after the response assessment?
Dr. Shefali, can I answer that question? I think what we would do in that situation is, first thing is, we wouldn't deem this outrightly unresectable. Now, this patient, except for the fact that this patient has acute DVT, and this patient's PS wasn't great just because she was not able to walk. That's the only thing which is limiting surgery in this patient. Otherwise, this is potentially resectable. The only thing is that in this particular patient, as I'm going to show you next in the next slides, we wanted to bide some time for this patient to be up and about and kind of be able to handle her right lower limb as well. So that's where we actually went ahead and chose chemotherapy in this patient. And just to briefly summarize on what was there in the last thing, there was some evidence of benefit of neoadjuvant radiation in the STRAS trial, as Dr. Somesh pointed out. Sorry, we don't have that much time to discuss it in length, but it probably says that in certain subgroups, there may be benefit, but then largely overall, it actually says that probably there wasn't really much advantage in terms of resectability, and the composite endpoint used was also kind of abdominal recurrence-free survival, which was something which was a very, very different kind of endpoint which had been taken. Neoadjuvant chemotherapy, it was summarized that it should probably be histology-driven for dedifferentiated liposarcomas, the high-grade leiomyosarcomas, and possibly for synovial sarcomas. And regarding adjuvant treatment, there was said it was kind of summarized that there was no proven benefit. If the margins were closed, the tumors were large. How large? It was not talked about. Recurrent tumors and dedifferentiated liposarcomas and leiomyosarcomas, basically trying to say that all those situations where the risk of recurrence would be high, we as of now do not know how much benefit adjuvant therapy would add to these patients. But then yes, it could be considered on a case-to-case basis. So coming to what actually we did in this patient was, this patient received 3 cycles of ifosfamide and doxorubicin, and obviously anticoagulation was given, initially injectable and then converted to oral anticoagulation. Dr. Shefali, any difference in choice of chemotherapy from your side?
So, I mean, I would agree with the choice which was used. However, gem-dosi is also a good combination which works in leiomyosarcoma. So, nothing one over the other, but ifosfamide and adria are also good choice in leiomyo.
Dr. Somesh, preferred regimen at your center?
I think this is the common regimen, but yes, gemcite-based regimens are also quite popular with her.
Okay. Dr. Pradeep, at your center, neoadjuvant chemotherapy would be?
I think it would be the same.
Okay, sir.
The literature would say that for leiomyosarcomas, dacarbazine is possibly has shown some more benefit, but we have not seen our medical oncologists using that very often.
Okay, so we go to the so this patient, there was with anticoagulation and chemotherapy, there was significant improvement in patient general condition. The lump persisted. There was only residual some edema over the feet of the patient. So I'll just play the CT again for this patient. Essentially, what we see is a very, I'll just go fast forward to the abdominal images. So we see that there is no new lesion which has appeared anywhere else, nothing in the bones, nothing in the liver, nothing in the lungs. And then the lesion largely remained the same. The only thing probably that had happened was that collateralization in the pelvis, as we'll go down the images, was slightly more. And you can see the thrombus more clearly defined in the cava. You can actually see the second part of the duodenum was involved in the with this, and the posterior pancreatic capsule was also involved by the tumor. And there was some cross drainage from the right lower limb which had developed in the left and probably going through the lumbar veins. So the next question at this point in time to Dr. Pradeep, sorry, Dr. Jitender would at this point in time, you already said that you would like to do a MR venography to say whether it's a bland thrombus or a tumor thrombus, but probably if you've done a PET scan and the tumor is FDG evident, the thrombus is also showing FDG AVTD, you would probably not be that keen on doing that. Sometimes when you have a doubt whether the KY is involved or it is just aborted, then you may, that MR venography may help a bit. So would you like to do, like Dr. Somesh has probably already answered, at your center, it's open to all three panelists, Dr. Pradeep, Dr. Jitender, and Dr. Tarun. We know that 80% of patients with retroperitoneal sarcomas will need an nephrectomy as part of the procedure. So would you consider a routine DTPA in all your centers? To be honest, we do in all our patients. Dr. Pradeep, Dr. Jitender, and Dr. Tarun. Please.
Yeah, not in all patients. If the kidney is visualized well on a contrast enhanced CT scan,
Yeah.
not required to daily.
Same.
If older patients, diabetic patients, and comorbid patients, then you can consider doing it, but not in all patients.
And Dr. Pradeep?
Yeah, correct. So we'll, I think CT scan should be fine in this patient.
Okay. So we go to the next question, Dr. Tarun. Prosthetic grafts and bowel anastomosis.
Right.
What is your take on that? So say, for example, you are doing a right hemicolectomy with a right-sided retroperitoneal tumor and there is caval involvement, you need a resection, or versus a left-sided resection. How would you go about in these patients differently?
See, prosthetic with the vascular team, with the vascular cover, of course, you would go with. I mean, you can offer or you can do a prosthetic graft in these patients. If it's a sidewall resection, a patch can be done using taking a saphenous vein or IJV or whatever is convenient to use. And I'm sorry about your question about the bowel anastomosis. Can you please repeat?
So basically, you would be comfortable with a prosthetic graft as well as a bowel anastomosis there on the right side, on the left side.
I'll be comfortable on the right side, not on the left.
So on the left side, Dr. Jitender, would you like to divert a patient who's undergoing a concomitant prosthetic graft and say, for example, anti-resection or a left hemicolectomy and anastomosis on the left side?
I would like to keep my suture line away from the process if possible, and would wrap it with some sort of tissue like an omentum or something like that. If that is not possible, I will definitely think of diversion in these patients.
Dr. Somesh, you would like to add something there?
Not really. I mean, if it is an arterial reconstruction, you have to use a prosthetic graft because that works best. And you have to see it, try and minimize fecal contamination and take appropriate isolation. There is a possibility of using an extra anatomic prosthetic bypass. You can do an axillofemoral bypass outside through the body wall. So that would make it safer.
So how would you decide in which patient you are going to do an extra anatomic or extra aortofemoral bypass compared to a patient in whom you are comfortable putting a graft there?
It depends primarily on the fecal contamination, I would say.
Okay. So by and large, most of these, as you said, also presented well, most of these would be planned operations. Most of the patient would have received a good mechanical bowel prep. You would have kind of used staplers as well. So the chances of having gross fecal contamination would be generally less in most of these situations. So you would, as I understand, most of the panelists would be comfortable having an anastomosis and a prosthetic graft. And sometimes we've seen our vascular guys, when they come in, they're trying to figure out some tissue, trying to put that tissue at least their anastomotic sites and picking up some peritoneum or some tissue and placing it over their two anastomosis if there is a interposition graft being placed. So this is actually what we did. This was the large tumor which was removed. This was actually replaced with right common iliac was reconstructed to the suprahepatic cava, infrahepatic cava, and the left renal vein. This was reimplanted into the graft. And this is just a schematic diagram showing what was resected. And there was a lot of collateralization in this patient, if you can see here. And this helped kind of get the flow from the right side to the left side and then to the cava. And so this patient actually underwent a en-bloc excision of the mass with nephrouretrectomy, right hemicolectomy, and along with resection of the IVC with a PTFE graft from the left common iliac to infrahepatic IVC.
So any comment? I have a question.
Dr. Jitender.
Yeah,
please.
So it looks like a type 2 involvement like leiomyosarcoma. and you have said that the patient had a good amount of collaterals, as I can, the edema also settled with the adjuvant chemotherapy. So
Yes.
she must be having good amount of collaterals. Could we have done without doing a vascular recon in this case, or a vascular recon was necessary?
So basically, I think that question is very, very valid. Now, the thing is that at this point in time, once you've given chemotherapy and there has been some response, some collaterals opening up, you don't know how much you can rely on those collaterals as far as the renal thing is concerned. You're knocking off one kidney. You cannot have the other kidney not draining back, and you want to be sure about that. Dr. Somesh could add something there probably.
Yeah, see, the edema was primarily in the right leg. So the collaterals were not enough for the left, maybe or one of the sides. So it is always safer if you can do it safely. There's no great urgency to bring the patient out of the theater. It's always better to drain the long-term patency rates with such a surgery would be excellent, and it is always better to graft such major vessels.
Yeah. And Dr. Pradeep, a question to you. When you use a prosthetic graft, venous side, you would anticoagulate these patients?
Sorry, no experience with the vascular grafts.
Dr. Tarun?
In our practice, yes, we are doing it.
Yeah.
We are
So
doing
we also kept this patient on oral anticoagulation. The same thing which was continued pre-op was given. So her final biopsy was grade 2 leiomyosarcoma. The margins were free. The patient was discharged on postoperative day 6. She received 3 more cycles of chemotherapy at 18 months. Fortunately, the patient is disease-free and with ongoing anticoagulation. So I think this brings us to the end of discussion on this patient. The second patient is a 50-year-old lady, abdominal lump, 1 month, no other symptoms, no medical comorbidities. Otherwise, a very fit lady, a large mass on the right side of abdomen. That's the scan I'll run. There was no disease in the lungs, bones, and in the abdomen. I'll just skip some part of it just to get to the main part where there is the tumor. There you start seeing the large tumor, fat containing lots of areas of calcification involving the right kidney. The right colon and mesocolon forming the anterior border laterally, and to some bit extending behind the mesentery of the small bowel slightly towards the left side without involving any major vascular structure. So, any comments on the findings?
Are these calcifications or are they vascularity of the tumor?
These are calcifications. They were there on the non-contrast as well.
Non-contrast. Okay.
They were there on the non-contrast as well. So probably this tumor must have been there for some period of time, and there must have been some areas of necrosis and then calcification. So, sorry. So this patient, would we like to biopsy? Dr. Pradeep? Dr. Pradeep, would you like to biopsy this lesion?
No. Yeah, no. So on CT scan looks like a well-differentiated liposarcoma. So
any difference opinion amongst the rest of the 3 panelists?
I think we can avoid in this case.
We can avoid.
I think this is one classic case. You see a classic liposarcoma, looking like well-differentiated, not showing much invasion around. Probably you could avoid a biopsy. And I think we offered surgery to this patient. Any difference of opinion amongst the panelists?
Surgery.
No new adjuvant treatment. I think so. This question was essentially intended to talk about. So the biopsy had actually been done before the patient came to us, reported as atypical lipomatous tumor / well-differentiated liposarcoma with no evidence of high-grade sarcoma. As I said, we do routinely DTPS in all these patients where we had to knock off one of the kidneys. So this patient actually had, sorry, the numbers are wrong. The right side is, the right side kidney was only, the GFR was only 10 ml and the upper figure is 53. So the total GFR was 53, the left was 43 and the right was 10. So a question to Dr. Tarun, when we operate upon well-differentiated liposarcomas, although I think Dr. Somesh has already answered it very well in his presentation about margins and resection. So either Dr. Somesh, you could just summarize that slide once again for everybody's benefit. It was a very beautiful slide and you could just summarize that slide. And as I understood, you said well-differentiated liposarcomas, you would be a little less aggressive in taking adjacent organs when you felt that there was an intact capsule around the tumor, as I understood. and probably there was probably poorly differentiated leiomyosarcomas because of higher risk of distant metastasis. You said that you would be okay not being very aggressive in the surgical approach, and rest everybody else you would be very aggressive. Have I summarized it right?
Absolutely.
Yeah. So I think that question is already answered. And unresectability, Dr. Somesh has actually already answered. One of the panelists could just summarize that or just add something to that.
I think the major vasculature involvement, the SMA root involvement, celiac axis involvement, aorta hepatis involvement, and involvement of circumferential involvement of aorta are the main unresectability criteria.
Spine involvement.
And to add what Dr. Somesh has already added, yes, spine and probably the lumbosacral trunk as well. And probably that summarizes the issue of unresectability. I think quite much of what would be deemed unresectable at a relatively, and that's where probably Dr. Somesh's last slide comes in, a pair of surgical skilled hands working in a center with available multidisciplinary surgical team with vascular background, need for a urologic background for a complex reconstruction. All things with a hepatobiliary surgeon or the surgeon himself being trained in hepatobiliary surgery would kind of make a lot of these unresectable tumors actually resectable. And so probably there would be a lot of scope for reviewing images for patients who have been deemed unresectable.
And
so,
Dr. Chandra has also mentioned about the divestment techniques which we have been using in pancreas now. So more and more patients will become resectable in future, I feel.
Yeah. And this patient underwent an en bloc excision of the retroperitoneal tumor with right nephrectomy, with a right hemiclectomy. Probably Dr. Somesh wouldn't agree, but we also actually went ahead and did a pylorus preserving pancreatic duodenectomy. This actually comes from one of our previous experiences, which I'm going to share next. And probably smarting from that case, we went ahead and did an aggressive approach in this patient. And so, any thoughts about adjuvant radiation in this setting?
No, I
don't think so. I don't think so. No.
We should not have. Yeah.
So basically, this case was actually discussed in our tumor board, and it was decided that whatever limited benefit, we should discuss the option with the patient. And actually, patient's relative was a doctor himself, and he did some literature search and came back and said that they wanted adjuvant radiotherapy. And so we've gone ahead and irradiated this patient, and this patient has been doing well at 16 months follow-up. So a question to Dr. Somesh as to when you plan new adjuvant radiation for these patients, like not for exactly this case, but for some patient, how do you go about deciding the radiation field? How aggressive you would be like, because sometimes these masses, there will be a lot of bowel loops draped around the mass, more so anteriorly. So how would you go about planning the radiation in this patient and deciding which side to go a little extra on the radiation, giving the full dose of radiation and coming down on the radiation at which site?
So we know the radiation sensitivity of the spine. Posteriorly, in the posterior space and lateral space, it's all abdominal wall, and the peripheral nerves are more radioresistant. More resistant to higher doses. So those areas you can have adequate doses. It's only when you approach the small bowel, not the mesentery, and the kidneys, that you need to be careful.
Okay. So say, for example, you have a patient in whom the tumor, I'm going to show that last slide if we have time. I think I'll just show that video. If, so
I have a question. Can I ask?
Please.
Dr.
Please,
Chandra,
sure.
I have a question with Dr. Chandra. He said a word of caution about performing pancreatic duodenectomy or Whipple's in right-sided compartmental resection. So sometimes, as you have mentioned, that while doing surgery or when you have immobilized most of the part of the tumor and you realize that you have to perform a Whipple's at that time to back out, it's very difficult. So do you decide deem these cases unresectable at seeing at the imaging only, or intra first you assess that part, whether you require a Whipple's or not, and how do you decide? So this is my question.
So I guess that question is directed at me.
Yeah.
So I would possibly in such cases try one, that it's not on the images that you declare them inoperable, because images do not reveal everything.
There is a lot of mass effect.
Correct.
These tumors are large. There is a lot of mass effect actually in these tumors.
If I go into the surgical details, I would probably hit the superior mesenteric vein at the level of the ileocholic vein, and then trace it up to the duodenal-pancreatic area, and see how much of that area, and then go above, but do a partial cauterization of the duodenum, see how much of the IVC is free, and if that area is stuck, but the histology is favorable, I would probably go ahead with a pancreatic duodenum in those cases.
Okay.
So basically, the third case is an older case. So this was a 48-year-old lady presented just with some abdominal discomfort, increasing girth. Imaging showed a large tumor. First time, I actually operated her 3 times. First time there was an excision of the retroperitoneal mass done. This surgery actually came out like a sebaceous cyst. Actually, we just mobilized the right colon, and the tumor we were able to lift. There was a very well-defined capsule all around it, and the biopsy came well-differentiated liposarcoma, and the tumor was focally reaching up to the capsule, but the margins were free. This is what we got on the biopsy report. So within a span of 3 years, this patient came back to us with a recurrence of symptoms. The CT showed a recurrent liposarcoma. I'll just play this video simultaneously. This is actually going from pelvis up on the video. And in this patient, actually, we reached a point which Dr. Jitender just asked Dr. Somesh. We actually were able to separate it everywhere. We got it, the right kidney we had planned, the right colon we had planned, but we reached a point where there was a capsule, but which could be easily separated from the duodenum, and we actually did a margin as well there. But this is the site where this patient actually recurred next, and so this was the tumor. We can see the right colon, the mesocolon, everything being lifted behind. And as we go up, we'll be able to pick out that area of the duodenum where it is just there. So very difficult to be sure that it's involved or not involved. So there you can see the pancreas, and that's where you have a lot of mass effect there. So we didn't know that it was adherent or not. At surgery, it actually came off very nicely. And so we went ahead, avoided a pancreaticoduodenectomy in this patient, and then subsequently, although all the margins were clear, I'll just go to the next slide. What we got was, sorry, the slide not moving. So in September 2020, on a routine follow-up, though the patient was asymptomatic, this was exactly the area where the recurrence was there, and patient afraid of having had 2 major surgeries and kind of very, very skeptical of having another kind of waiting for another recurrence. That's the area where you can see a small area of recurrence right at just behind the pancreas. You can see some clips there that you can see the third part of duodenum there where the tumor recurred. And in this particular patient, we actually went ahead and did a pancreaticoduodenectomy. So in this patient, like the third recurrence, would there be a difference of opinion in treating this patient with neoadjuvant therapy at this point in time? Dr. Somesh pointed out a very well said thing in his presentation that in some of these patients, probably you could wait and let them have a symptomatic recurrence before you go ahead and resection. Dr. Pradeep, you want to comment on that?
Probably yes, because the recurrence, we can wait and see, because I think the third surgery was a very difficult surgery, what you did. So I don't know what the patient symptomatic before the third surgery. How did we pick up the third recurrence?
No, it was a routine follow-up. The patient was asymptomatic, a routine follow-up.
And we went ahead and did a surgery without any neoadjuvant this time also. Already radiation was given.
No, the second time the patient was advised radiation, but the patient actually decided not to take it. She visited 3 or 4 radiation oncologists, and after a discussion with them, probably the risk-benefit ratio, the benefit not being that great, and so that's where it was placed to the patient. The patient decided not to go ahead for radiation. And
I think this is one case where I would probably not wait. The tumor is situated in such an area that it could become inoperable or require a much more larger resection, which would need to be combined with a PDR. At present, this is just a PDR as extended form of PDR. As the tumor grows, maybe if involves the IVC or the mesenteric root, then it's going to be a difficult situation. So I think this is one area where, and if it is not a high-grade tumor, if it's
this was a well-differentiated. It was a well-differentiated liposarcoma.
So this is one issue where I would probably not wait too long, because it's close to the superior mesenteric, and that could be an area of inoperable. See here, you are not combining a large resection with a PDR. It's a small resection with a PDR. Here the main surgery is PDR. and the
Yeah,
other says
yeah.
the rest is small.
Yes.
So probably, I don't know, somehow I was not aware of the fact that you could actually wait on these tumors before your presentation, Dr. Somesh, I must admit. So maybe we just went ahead, did an en bloc excision of the mass with a pancreaticoduodenectomy, and this patient has been doing well. Dr. Shefali, do we have time? Just 2 minutes for this last case?
Yes, please. You can quickly.
So basically, I actually, 48-year-old, this is actually a male patient, presented with a large abdominal lump. Biopsy was a low-grade leiomyosarcoma. And this patient, actually, we felt that we could resect this tumor, but this patient wasn't too keen on an extensive resection, more so when we told them that it may need a large vascular resection. There were some cost considerations as well. So I'm just playing the scan of this patient, both the arterial and venous phases. So this patient, as we go ahead, so that's the tumor. It starts off here behind the SMA in front of the aorta, crossing over to in front of the IVC, extending to the lateral abdominal wall, involving the psoas. And there on the venous phase, you can see the whole extent of the lesion. And if we go back and see, this tumor is actually going around the iliacs as well. So, Dr. Tarun, Dr. Jitender, any panelists, this is more like a learning for me as to how you would approach this patient. Dr. Pradeep, we could go in that order. Dr. Pradeep, Dr. Tarun, Dr. Somesh, Dr. Jitender. That's how you people are on my screen.
Yeah, so first I think we should take a biopsy, which I think it's been done. Low-grade leiomyosarcoma is the biopsy. I think it is more or less looking unresectable to me as of now. So yeah, maybe a trial of neoadjuvant chemotherapy, as we decided earlier, 3 cycles, and then reassess.
Dr. Tarun, any comments on that?
I agree. It doesn't look, I mean, R0 will probably not be possible, but I would still counsel the patient. I would still give a shot of surgery, as in, without sacrificing major structures or no multivisceral resection, but I would kind of still venture in.
You would need a multivisceral resection. The left colon would be very difficult to salvage. The external iliac, you see tumor going behind the external, bifurcation of the left common iliac. So probably that would also
see this being low grade, this patient is not going to have a very good response to chemotherapy either.
Dr. Somesh?
I would be a little more aggressive on the workup. I would probably do a PET and see if there are any high FDG avid areas. Because in such a large tumor, all the areas may not be low grade. If there are some certain high grade areas, and we have a reluctant patient, and all the wrong kinds of combinations to bring this patient out from a successful surgery, I would lean more towards a neoadjuvant chemotherapy and find myself and for the patient a reason not to do the surgery now. 4 cycles down the line, patient would be more convinced. I would be more brave, and possibly we could do the surgery at that time.
Dr. Jitender?
Yeah, low-grade leiomyosarcoma, I think chemotherapy is unlikely to help. As Sir has mentioned, if there is a role of PET, we can find out some high-grade areas. Otherwise, it looks a very aggressive tumor. R0 seems unlikely in this case, I feel.
Dr. Somesh, I come back to you. And
Dr. Vivek, just 1 second. Sorry to interrupt again.
No,
so
okay.
how comfortable you are when somebody labels it as a low-grade leiomyosarcoma? So as far as our general understanding is concerned, so leiomyosarcoma by default, we take it as high-grade. So I agree with Dr. Chandra sir. To get a FDG PET and see the most FDG avid areas, because tumor may have a heterogeneity here. So to make sure that it is really a low grade would be a matter of concern. Because
Madam, then we should put it as, suppose it doesn't have a good uptake and it actually is low grade, then what do we do in this case?
Dr. Tarun, that is what I'm coming to actually. So because if it is a low grade leiomyosarcoma, your all concerns are very valid. That chemotherapy may not be a good idea. That is why, I mean, KI 67 or for that matter, proliferation index would matter. So if you are taking a chance to make it resectable for that matter, so you should be sure of where we are heading towards. So if we are planning a neoadjuvant intent chemotherapy, the intent should be clear actually. That is how it is.
And I think
Right.
somewhere along the line, Dr. Shefali, we should have had a radiation oncologist on board as well. We are missing that person because
Absolutely. I agree today.
we got a medical oncologist, the radiation guy is sitting quiet. He's not there because.
Do we have?
I have a question.
Do you have any idea about the time course of the symptom duration?
For this patient, sir,
Yes.
this patient has been having this lump for the last 5 months, progressively increasing.
Right.
Yeah.
So it doesn't quite, the pathology doesn't fit. So more than a radiation oncologist, I would have a pathology review.
Absolutely.
I'll get some investigative molecular markers and some genomic studies. We are desperate now to find something more than a surgery, because surgery is, as going by the general standards, is not going to be a very attractive option in terms of local tumor control.
Right.
And this patient with a leiomyosarcoma still remains at high risk of distant metastasis.
Completely agree with you, sir.
Any situation where you would use neoadjuvant radiation?
Not in this case.
Any situation where you would use neoadjuvant radiation?
So you had shown one patient where the tumor was largely lateralized. It was the one in which you had done multiple surgeries. That was one patient where I would probably have
done the IBC leiomyosarcoma?
No, the one after that.
Recurrent
the liposarcoma.
Yeah. So that was a good case for radio painting.
Okay.
Can I have a question to Dr. Shefali?
Yes, please. Yeah.
How has been your experience with giving chemotherapy in such, suppose it's a high-grade tumor, leiomyosarcoma? How has been the response rate, and what do you expect the response? Is it the downsizing the tumor, or are we testing the biology of disease?
So both ways. So we do not, as a routine, practice neoadjuvant in sarcomas actually, but in such cases where, you think that it is potentially resectable, or for that matter, you need to buy time. What I mean by potentially resectable, not technically, or you think that it is unresectable. So in those cases, we can give chemotherapy in by default high-grade sarcomas. By default, when I say, I mean there are some kind of sarcomas which we take by FNLCC grading by default as high-grade synovial ho gaya. Then you have this high-grade leiomyosarcoma. You have MFH sometimes. So these sometimes respond beautifully to chemotherapy. But of course, we are not looking forward to a CR kind of situation. We are just downstaging and to buy the time and select biology in that.
So there can be significant volume reduction if there is a good response to chemotherapy, right?
Yes.
Okay.
So, Doctor, any of the panelists, what has been your experiences with? I have very limited experience actually. And so what has been your experience with neoadjuvant chemotherapy or radiotherapy and resection of retroperitoneal sarcomas?
Preoperative radiotherapy should not be too much of an issue. Most of the time, because we know that chemo is not a very attractive option. So most of the times when you're using it in the neoadjuvant setting, you are kind of in a desperate or helpless situation. Many a times the patients would progress, at least 25-30% of them would progress, and then they never come to surgery at all. So
I think somewhere along the line, we have to understand that we could just go back to the 2 weeks back Webisode, and what you realize is that significant proportion of these patients progress. Some of them respond and some of them regress, and then some of them would actually remain the same. So actually, if you see neoadjuvant chemotherapy, neoadjuvant radiation, whatever data you see, most of these situations, these tumors would progress rather than stay the same or regress with neoadjuvant chemotherapy or radiotherapy. And probably that is why the role of neoadjuvant chemotherapy and radiotherapy hasn't really come up in a big way for retroperitoneal sarcoma. I think with that, I'll just come to my summary slide. And so essentially, retroperitoneal sarcomas are uncommon tumors. There's wide variation in practice. And as you could have seen with all the panelists, there is quite some difference in opinion. The literature remains sparse, not definitely conclusive. Surgery largely remains the mainstay of treatment, and quite often multivisceral resection and complex reconstructions would be required. The role of neoadjuvant and adjuvant therapy as of now is not that well established. The clear-cut cases where one would definitely give, and probably that is why the middle path would be that you tailor the treatment to the patient's condition and the available expertise, and having a fair and square discussion with the patient as to what do they expect with surgery, what to expect with neoadjuvant therapy. That is what is going to help us finally have patients who are understanding the extent of disease, the extent of operations, the associated morbidity, and the risk of recurrences as well. Thank you very much. Thank you, everyone.
Dr. Vivek, you can take up the questions also from chat box. I think there are a couple of questions there.
Yeah. So basically, so the first question is, what is your call on giant retroperitoneal well-differentiated liposarcoma occupying in a 76 male involving right kidney, IVC, iliac arteries, 180 to 270 degrees, role of neoadjuvant RT in such cases towards such radical surgery, such old frail man? I think the most important thing would be the performance status rather than the age would be the biggest concern. If you have a patient who's got a poor performance status, significant comorbidities precluding a major resection, this patient would anyways be going towards a palliative approach rather than anything else. As far as neoadjuvant RT is concerned, I think Dr. Somesh has already answered that this would be a case where he would be happy using neoadjuvant radiation. Agree, Dr. Somesh?
Not necessarily. This is where this patient would need an iliac artery resection, possibly if it is infiltrated. So why not knock off the kidney, the tumor, the iliac artery, and reconstruct it? That's it. That's his best palliation. It's not going to be a curative treatment. So I'm not going to add anything more for palliation. One single.
Okay.
If he's medically fit.
Okay. And if medically unfit, then you would consider radiation in this patient, or
then it's like a homeopathic medicine for radiation also.
Okay. Oh, I like that. We don't have a radiation oncologist. That's why you're able to say that.
No, there'll be no effect. There'll be no side effect. So that's all I would say.
No, I get that. I get that point. So somebody's asked, what about intra-op clip applications, and if recurrent tumor or high risk of recurrence regarding post-op RT and using prone position and localized RT for post-op RT? Anybody could take that question.
So clips can only guide you. Clips can only guide you about whether the recurrence is in the same area or a higher area, close margin area, but it's not a guide for radiation because you need to radiate large margins. So not as a guide.
Basically, we don't have a radiation oncologist, but mostly the radiation people would kind of look at the original scan of the patient before the surgery, mark out the areas which were in close approximation to the tumor, and try to encompass all that in the radiation dose, in the radiation planning when they look at it, rather than just the small area where the clips are there. I think that should answer the question. So,
Dr. Vivek,
yeah,
if I could just comment on this, if there is if any area is there where you feel you have left the tumor, or there is a place where you feel the tumor was close, very close to this thing, so probably the clips could guide the radiation oncologist to give a boost in that area. So yeah. I think clipping the areas where I don't know, Dr. Somesh, what is his views on this? That if anywhere when you feel that even when you're doing surgery, you feel that this is the area where probably I'm not very sure of the margins. So there, if you put a clip, probably that if we are thinking of post-op radiation, if at all, so probably a boost could be given to that area.
So we go to the next question. Post ifosfamide adriamycin, no major response. What was done next? Thrombus still there, duodenum still there. So I think we've already answered. Dr. Gagandeep, I believe you've got the answer to this question. If the patient is fit for surgery, this patient would be taken up for surgery, and whatever kind of it takes. So the next comment from Dr. Raza Saeed is that pattern of recurrence of LMS is distant mets. Retroperitoneal LMS is unlikely to be low-grade. Pre-op systemic therapy will help identify patients who develop systemic disease during chemo. I think this is what most of us would also came around agreeing, that if there was an LMS in which there were probably high FDG areas, or there was significant risk of recurrence deemed, so some of these patients could be considered for neoadjuvant treatment, with the caveat that very few of these patients respond. The only thing that we're trying to assess is the biology of the disease, that this patient should not come back with lung bone mets very early. And he's mentioned the STRA study as well. It was discussed at length in the previous webisode. So Dr. Rudra has asked, any role of targeted therapy in high recurrent tumors spread over 8 to 10 years? Dr. Shefali, that's for you.
Yeah, so I mean, if you are able to resect every time with a good margin, I don't think there is a role except for desmoid. So the recurrent desmoid, we have the clarity on it. Otherwise, targeted therapy, these are, I mean, cold tumors. Sarcomas are generally cold tumors. They do not have too much of targets, actually.
So desmoid, what are you doing?
So in desmoid, there is a role for imatinib in the recurrent setting, where you deem that, okay, the next recurrence would make him really unresectable, or it would be too morbid. So that is the situation.
Yeah, and for desmoid, there is some evidence that you could do ER/PR status, and if the ER/PR is positive, you could use tamoxifen as well.
Absolutely.
But I think the tamoxifen being used in this is high dose tamoxifen.
It's high dose. We are not able to achieve that kind of dose many times. So we generally use modified. Yeah.
So I think with that, we come to an end to the presentation. I'll stop sharing my screen. Concluding comments from Dr. Shefali and Dr. Nikhil, if he's still around.
Yeah, so thank you so much. Wonderful discussion. I didn't think actually when we planned for sarcoma in last session and this session that it could be so interesting and so thoughtful to have a, I mean, good discussion on it. So I really thank you, all of you, so that, I mean, you took out your precious time to enlighten us. And next we'll be discussing on colon. And after that, I think we'll be winding up for the first 1.5 years of this effort and taking it to the next level, I think.
And I think we must congratulate Dr. Shefali and Dr. Nikhil for running this continuously. And that's
so
a very good
it's all because of all of your support, everyone's support. So taking out time, having this good academic discussion for 1.5 hours, it really, I mean, means a lot. Thank you so much.
Thank you, everybody. Thank you, please. And good night, please.
Thank you.
Thank you.